Hello, I'm Dr. Sharona Dayan, a Harvard-trained board-certified periodontist and a student of Joy Moeller and Samantha Weaver. I also have a specialty in oral medicine and a doctorate degree in oral cancer biology research from Harvard University. These days, I'm spending most of my time in clinical private practice in Beverly Hills, California. And I also love to teach dentists, periodontists, and hygienists. Now, in today's modern society, it is almost impossible to get ahead of periodontal disease and peri-implant disease if we ignore the way we breathe, the way we sleep, and the way we swallow. So today I'm going to talk about three things. First, that this global epidemic of sleep disorders is contributing to periodontal disease and peri-implant disease. Second, that myofunctional disorders like mouth breathing, tongue tie, and tongue thrust are risk factors for periodontal disease and should be included in our assessments. And third, I'm going to talk about the role of the periodontist in removing lip and tongue restrictions. And this is an opportunity for us to use our plastic surgery skills and deliver results that are beautiful and functional. So let's get started. For years, we have been telling our patients to brush more, floss more. Today, we have toothbrushes with the most advanced technologies. We have oral hygiene aids galore. Americans are seeing the dentist for professional cleanings more than ever before. So why is gum disease still the #1 leading cause of tooth loss in America? And what is up with all of these failing dental implants? And at the same time that we're seeing more teeth being removed for gum disease and more problems with dental implants, we are seeing a worldwide epidemic of sleep disorders. Every country that is organized enough to have a sleep center is reporting sleep disorders in record numbers. And the World Health Organization has designated America a sleep-deprived nation. 80% of Americans don't get the sleep we need, whether it's the quantity or the quality. So we need to get 8 hours of sleep, and we need to go through all the stages of sleep, including deep non-REM sleep and REM sleep. So these disorders can be disorders of quantity, quality, or both. So how do these sleep disorders contribute to periodontal disease? Well, when we have a situation where there is sleep apnea or where there is snoring, or if the arches are small and the tongue doesn't have enough tongue space, and when we sleep, the tongue goes into our throat and chokes us at night, all of these are situations that set us up for mouth breathing. So as a consequence, we get dry mouth. There's 42% more water loss with mouth breathing than with nose breathing. So what are the problems with dry mouth? Well, we lose the buffering capacity of saliva, so the mouth gets more acidic, and we know that periodontal disease bacteria love acidic and anaerobic environments. And then we lose lubrication, so our teeth and our gums just get more sticky and become a breeding ground for bacteria. There's less salivary IgA that's very protective, and there is less of the healthy microbiome. So all of this sets the stage for a dysbiotic oral cavity. And in fact, in this study of 33 nose breathers and 33 mouth breathers who had gingivitis and they were undergoing scaling and root planing, the nose breathers had significantly better outcomes. And in my practice, one of my goals is to help my patients become nose breathers if they aren't already. And some of the tools that I use are referrals for myofunctional therapy to the Buteco clinic and Patrick McKeown, and mouth taping. These are just some of the tools that I use to help my patients, but it's always my goal to get them to breathe through their nose. Now, there is another aspect to sleep disorders that affects the oral cavity. Most people with sleep apnea also have reflux. And Steve Park, MD, in his wonderful book, Sleep Interrupted, talks about how this acid from the stomach comes into our ears, into our sinuses, into the mouth. So again, we have a more acidic environment that the periodontal disease bacteria love. And also we have the stomach contents coming up into the mouth, bringing with them H. pylori, a bacteria that belongs in the stomach, not in the mouth. And again, this can contribute to the dysbiosis. And I would love to see a study of sleep apnea patients who get evaluated for their level of periodontal disease, for their pH in the mouth, and some salivary DNA testing for H. pylori. So we have a more acidic environment, we have a drier environment, and those are biochemical reasons that sleep disorders contribute to periodontal disease. And then there is the biomechanical factor. Patients with sleep apnea also grind their teeth. And in this study, the degree of tooth wear was directly correlated with the severity of obstructive sleep apnea. And when we grind our teeth, we're applying lateral forces that are not favorable. For years, we have known that lateral forces on the teeth contribute to bone loss if there is periodontal disease present. And I know 8 years ago when I was getting trained in LANAP, laser periodontal surgery, they really emphasized addressing occlusion as part of therapy. And I've been paying more attention to this in the last 8 years. And it happens without fail that the teeth that have the most bone loss have lateral forces and unfavorable occlusal stress. And the recent classification by AAP for periodontal disease now includes tooth wear as a risk factor for the classification. Now, what about the lateral forces applied by the tongue during tongue thrusting? Patients who are mouth breathers have a low tongue posture. And so when they are swallowing, it's hard for them to posture against the palate the way that they should to create the seal for swallowing. So the only way they can get the seal is to push the tongue against the teeth. And this is a tongue thrust. And as early as 1954, Dr. Ray, who was the chair of perio at UCSF, published a paper on the effects of tongue thrusting as a risk factor for periodontal disease. And somehow this information has been lost, but it's time to bring it back. And myofunctional therapists have special devices where they can measure the tongue strength, and the tongue can apply 4 pounds of pressure on the teeth every time we swallow. So imagine that we swallow 500 to 1,000 times a day. That's a considerable amount of force. And it's strong enough to contribute to periodontal disease, to gingival recession, and teeth shifting. And I love the title, the book 6-Foot Tiger in a 3-Foot Cage, that is about our shrinking jaws and lack of tongue space. And let's remember that the primary function of the tongue is to dilate the airway. And so if the brain is sensing that there is an airway problem, it's going to try to use the tongue to open the airway. And this also is going to create a tongue thrusting situation for breathing. So let's take a look at a couple of cases, and I'll show you how I incorporate some assessments into my regular clinical practice. So here we have a patient in her 60s. Her chief complaint was that, my dentist told me I need a gum graft, and I just noticed this crack on my front tooth, and I don't like it. So some of the questions that I did ask, and I'll tell you the responses. How's your sleep? Terrible. I go to bed at 1 a.m. and I wake up at 5. Do you wake up in the middle of the night to go to the bathroom? Yes, a few times. Now, when we're in deep sleep, we make antidiuretic hormone, which keeps us from waking up to interrupt the repair process of sleep. So a patient who is getting up to go to the bathroom at night, to me, that means they're not going into deep sleep. And the same with children who are bedwetting. That's usually a sign that they're not in deep sleep and they're not making antidiuretic hormone. Do you have a hard time staying asleep? Yes. Do you snore? Yes. Are you aware of mouth breathing? Yes, sometimes I catch myself during the day with my mouth open. Do you wake up with a dry mouth? No. Do you have frequent headaches? No. Do you feel tired during the day? Yes, but I go running and then I feel better. Now, this is a woman who is very thin with an extremely healthy diet, and she's tries to stay active. This is not your typical overweight male old person with sleep apnea. Okay, so we have to kind of get away from that stereotype. Do you have anxiety? Yes. So patients who don't go into deep sleep and they're not well rested are in a constant fight or flight mode during the day that can contribute to feelings of anxiety. And also patients who are mouth breathers are typically shallow breathers who are overventilating, and they're losing too much CO2. So biochemically, they become anxious. And this is something that Patrick McCune with Bucheco breathing addresses so well. And I often refer my patients to his website and to his Zoom classes to help them. So anxiety certainly does have a psychological component, but there's also a very strong biochemical component that is rooted in a lack of deep sleep, inadequate sleep, and mouth breathing. Were you breastfed or bottle fed? Only bottle fed. Did you have a tonsillectomy? Yes. Did you suck your thumb as a child? No. Did you have braces? Yes. Did you have teeth removed for braces? No. When you don't wear your retainer, do your teeth shift? Yes. Well, this is an indication that there is a myofunctional disorder, because if the muscles of the face are in balance and they're functional and the patient is nose breathing, teeth really shouldn't be shifting. Do you grind your teeth? Yes. Do you have TMJ, as patients call it? Yes, I have clicking in my joints and I have trouble opening and closing. I also have trouble chewing. My ear, nose, throat doctor told me that I need a TMJ appliance, but my dentist made me one that goes on the top teeth and it's so uncomfortable. I have a really hard time wearing it. Now, this is a clue that they lack oral volume because the tongue already doesn't have the space that it needs. So any materials that take up more tongue space, like night guards that go in the top arch, are not going to be tolerated well. So let's take a look at her x-rays. So clinically, we saw that she had advanced gingival recession. She has a little bit of root resorption. She has bite collapse. She has occlusal trauma. She has 6 millimeter probing depths in her premolars and molars with severe bleeding on probing. She has mobility. And based on all of these factors, her classification, I would classify her as AAP stage 4, grade 3. And she has buccal ties, she has a tongue tie, she has a high arch palate, which to me indicates that when her jaw was developing as a child, she was a mouth breather. I did a home sleep study using sleep image. This is a device that Dr. Tom Colquitt told me about, and I'm sure he'll mention it in his lecture for this Congress. Her sleep duration was only 5 hours, and her sleep apnea index, 29, pretty high, and she had a lack of REM sleep. So in a lot of my young, healthy female patients who are tired and they get 8 hours of sleep, 9 hours of sleep a night, but they still wake up tired and they also get headaches, I find that they might not have sleep apnea, but none of them go into REM sleep. And deep sleep, whether it's deep non-REM or REM, are the stages of sleep where our brain repairs our body and our mind. So her overall diagnosis, she's AAP stage 4, grade 3. She has orofacial myofunctional disorder. She has a sleep disorder, so I don't personally diagnose sleep apnea, but I can tell if somebody's sleeping or not. So she has a sleep disorder, both in quantity and quality, and a lack of REM sleep. So today, how would I approach her treatment? I would not jump into gum grafts at this stage. So first I would fit her for a pod appliance. This is also an appliance that Dr. Colquitt talks about. It goes on the bottom teeth. It's comfortable for the patients. It protects the teeth from wear, and it has a patented design where the tongue is passively postured on the roof of the mouth during sleep. And this is so important, and it's why one of the goals of myofunctional therapy is to develop a rest posture of the tongue on the palate. Because during sleep, when the tongue is on the palate, it's activating the glossopharyngeal nerve, which is tied to the vagus nerve. And that increases the parasympathetic system during sleep. So we want our patients to be in parasympathetic mode during sleep so they feel, so they get better sleep. Then I would refer her for oral facial myofunctional therapy. Also for my patients who are having trouble sleeping and have disruptions of the microbiome, I do get their D3 and B12 levels tested. So I was trained by Dr. Stasha Gomanak in the right sleep method. So I have them go to the labs to get some testing. And if their levels are not optimal, I will refer them to her website to make sure that those levels get corrected. The myofunctional therapist will indicate to me whether frenum releases are indicated. And then when I know that she's sleeping better, when I know that she's breathing through her nose and she's not tongue thrusting, that is when I'm going to approach her periodontal treatment, because she's going to be set up now to have the best results possible with therapy. Okay, so let's take a look at another patient. She came to me with this chief complaint that I'm scheduled for dental implant surgery. I don't know if I should go through with it. I don't know what to do. I don't know what's wrong with me. I've had trouble with my teeth all of my life. And she is very frustrated and very agitated. Okay, so let's go through a brief assessment. How's your sleep? Terrible. Do you wake up in the middle of the night? Yes, many times. Do you have a hard time maintaining your sleep? Yes. Do you snore? Yes. Are you aware of mouth breathing? Yes. In my 20s, I noticed I would fall asleep with my mouth open. Do you wake up with a dry mouth? Yes. Do you have frequent headaches? No. Do you feel tired during the day? Yes, I am very tired. I have brain fog. I am so tired. Do you have anxiety? Yes, I have terrible anxiety. Were you breastfed or bottle fed? I don't know. My mother is dead and I don't have that history. Did you have a tonsillectomy? Yes, at the age of 2.5. So that's a very early age for tonsillectomy, and that's a clue that even in her early stages, she was a mouth breather. Did you have braces? Yes, for many years. Did you have teeth removed for braces? Yes, I had 4 teeth removed for braces and 3 more teeth removed recently because of periodontal disease. So the reason that I ask about this is it's not because the extractions and the braces cause these airway problems. Clearly, she was having airway problems probably from the time she was born. Okay, so these were problems she was already having, and she didn't have the right craniofacial development. Her teeth didn't erupt into good position. So she already had these problems. But when the teeth get extracted and retracted, then the problems just become a little bit more cemented. Did you suck your thumb as a child? Yes, until I was 6 years old. When you don't wear your retainer, do your teeth shift? I don't wear my retainer ever. Do you grind your teeth? Yes. Do you have TMJ? Yes, I have clicking in my joints, and I can sometimes wake up with jaw pain. Do you have TMJ pain? No, I don't. Okay. And so clinically, we see that she has advanced periodontal disease. She has lip ties, she has buccal ties, she's missing multiple teeth. And this is the scan that was sent by the doctors who were planning her implants. So she has advanced bone loss, and she was actually scheduled for the implant surgery. Now, I was trained in implants by Dr. Carl Misch. May he rest in peace. He was one of my favorite mentors and teachers. And he was really the only clinician who talked about tongue thrusting. And he would teach us to look for scalloped tongue in our assessments and to look for tongue thrusting behaviors during the exam. And he would teach us that a tongue thrust can keep an implant from osseointegrating, or if an implant does osseointegrate, a tongue thrust can actually cause bone loss around the dental implant. And I'm very grateful that he taught me that early on. And I don't think that this patient is a candidate for implant surgery right now. And so again, clinically, we have the lip ties, we have the buccal ties, the tongue tie, and you can see this big dip in her tongue, indicating a restricted tie. And look at the size of her tongue compared to her airway. This is, the 6-foot tiger in a 3-foot cage. And so my treatment plan for her, I would start with myofunctional therapy. So I have referred her to Joy Moeller, and I also would maybe refer her to Dr. Bill Heng or an orthodontist to maybe think about some expansion and take it from there. Really only when she gets used to breathing through her nose and we talk about her space issues and her oral volume and these issues get resolved, that I would think about the implant therapy. And just briefly, this is a patient in his early 40s who came to me with the complaint of the gum recession, that he already had some previous grafting done, but he said, I'm just so worried that I'm going to lose my teeth. So I was looking and I saw that he has, he has the 6-foot tiger in a 3-foot cage, and he has the tongue tie. He wakes up several times during his sleep. And I asked him, he has been through orthodontic treatment 3 times. And in his teenage years, he had a headgear retraction, and he was bottle fed only. He was never breastfed. And I asked him, I said, I think that your tongue is pushing against your teeth. And he jumped up in the chair and he said, yes, he said, I feel it. I feel my tongue constantly pushing against my teeth. And so for him too, this referral to myofunctional therapy, maybe for an alpha appliance, addressing his tongue restriction. I want to get his tongue away from his teeth and get him breathing more through his nose. And so I'm showing you these cases with advanced bone loss, advanced gingival recession. These are advanced cases. So we're not just talking about mouth breathing causing gingivitis. Okay, and I'll take you through one last case. This patient came to me concerned about couple of her dental implants, especially the one in the front that she said has drainage all the time. And these are her x-rays. And so she lost her teeth and now she's going to lose her dental implants. So if I just briefly take you through her history, she was also, as a child, a mouth breather. She sucked her thumb until 6 years old, and she had asthma as a child. She had a deviated septum. So again, I'm seeing all the signs of childhood mouth breathing and the sequela that have haunted her. She's in her 60s now, all of her life. And so she is so upset that she lost her teeth, went through a lot of reconstructive surgeries and prosthetic work. Now she's going to lose her dental implants. And, you know, this is what happens when the breathing pattern, when the tongue tie, when the tongue thrust, you know, get ignored. Okay, and again, this is some of her history. Again, we have the 6-foot tiger in a 3-foot cage, and she feels like she's had problems with her teeth all of her life. And this is her CAT scan. Her airway is a little bit narrow, and if you look carefully, you'll see that her tongue is not posturing up against the palate. There's no seal and there's a little bit of a gap there. Okay, and here is her clinical appearance. So now let's talk about the role of the periodontist in removing tongue and lip restrictions. So one of my goals in removing these restrictions is also to get the best aesthetic result possible. So here we have a situation where there is a lip tie and also gingival recession around her beautiful veneers. So the way that I'm going to approach this surgery is to address both in the same surgery, and I use an internal release approach. So I'm going to tunnel using, you know, Pat Allen's tunneling technique, and my frenum release will all be done internally without any external incisions to avoid scarring. And so when I lay the alloderm across the 6 front teeth, I'm also going to make it wide enough to deepen the vestibule and to help release the tension from the lip tie. So I want to give the lips full mobility and range of motion so that they can have a good lip seal to promote nose breathing. And this result is the after picture was taken several years later. So with the alloderm, this makes it a very stable procedure. And this is also a patient that I treated just recently. This is Joy's patient, and she doesn't have gingival recession, so I will need to do an external lip release, but I'm going to make my incision as small as possible, and I will still undermine the connective tissue and lift it off of the periosteum to the laterals to create space for the alloderm. So I always will use the alloderm because it's dense connective tissue with elastin that's really going to help relax everything and prevent reattachment. So for the alloderm, I want to get primary closure. We want to avoid graft exposure as much as possible. And this is a week later, so she's still in the early healing phases, but you can see that we have primary closure. There's no exposure of the graft, and this is going to heal really nicely. Now, I might, when she heals up, just go in and do a slight plasty here, just to even out the tissue right there. And again, here we have a lip tie and gingival recession. So I'm going to use the combination surgery of addressing the recession with the tunnel technique. And you can see now I have gotten full release of the tie with only using an internal release. Now, in this situation, her papilla, and you can see on the left, the alloderm is quite wide because I do also want to do a little bit of a deepening of the vestibule. And her papilla between 23 and 24 was very narrow and fragile. And I didn't want to risk separating the papilla by sliding the alloderm through the tunnel. So I made a very, very small access incision right here for the alloderm, and addressed the gingival recession and the lip tie at the same time. Well, the tongue is a small thing, but what enormous damage it can do. I hope that this lecture has just brought a little bit of insight into the periodontal complications of myofunctional disorders, mouth breathing, and sleep disorders, and that we will think about periodontal disease in a slightly different way and incorporate these incredibly important assessments and bring in our team of myofunctional therapists, breathing specialists, ear, nose, throat doctors to give our patients comprehensive therapy with the absolute best chances for complete recovery, to help them save their own teeth, and also to maximize the chances for implant success. Thank you so much for watching this program.